This meeting is now being recorded.
Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give an overview of our free program for those attending for the first time. So we'll go over who we are, what is our program, some upcoming events. We're going to introduce our speaker, Joel Lamore, and then we'll have a Q&A session at the end. So again, my name is John Furman. I manage the National EDS Awareness Program based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group. She was diagnosed with EDS in 2008, the same year my wife passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. We introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their communities. We've started over 40 groups to date. Each group is given their own free website with a link from the directory and map. In July, we'll be a sponsor again at the EDNF conference for the third time in Houston, Texas. We received feedback from these conferences that they provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Speaker Series. We meet every first and third Wednesday, typically at 7:30 p.m. Eastern Standard Time. All the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected for EDSers. The store is the only funding for this program and usually covers our monthly web fees. So just a general disclosure, this presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you are having medical problems now, please call 911 and get the services that you need. Always consult your doctor before making any changes to your treatment.
Our speaker for July 16th is Dr. Peter Rowe. He's the Professor of Pediatrics at the Johns Hopkins Children's Center in Baltimore. The topic he will present is managing orthostatic intolerance in EDS patients. And just a reminder, we'll be a sponsor this month at the EDNF conference, which is held in Houston. Our speaker tonight is Professor Joel Lamore. He is the Canadian Section Chief to the UNESCO Chair in Medical Bioethics. UNESCO is the United Nations Educational, Scientific, and Cultural Organization, which promotes international collaboration and is known as the intellectual agency of the United Nations. Professor Lamore is an instructor with National Defense and has served as a director of CPD and associate professor of psychiatry and CPD at Western University. He has received many teaching awards. He is an associate scientist at Lawson Research Institute and inspector surveyor with the Accreditation Canada. Joel has been a pharmacist at London Health Sciences Centre and is currently the director of EIM Care. His focus includes medical psychiatry, PTSD, Substance Misuse and Evidence-Informed Medicine. He has been published over 150 times on mental health, medications, and their effect on patient quality and quantity of life. He is a peer reviewer for many journals and an expert contributor. After the presentation, there will be opportunity for Q&A. Add your questions at any time during the presentation by clicking on the Q&A icon located at the top of your screen. After typing your question, click the orange button to submit. So at this time, I'd like to welcome Professor Lamore. We're looking forward to your presentation, and you'll see that your slides are loading on the screen. I'm going to go ahead and turn the microphone over to you.
Thank you, Deanna and John, so much for your hospitality. This has been an exercise that we've been working on and planning back and forth for a couple of months now. It's an absolute pleasure for several reasons. Before I get into the discussion, Deanna, thank you very much for the introduction. My mother isn't on the line, but I'm sure she'd be impressed. So I do appreciate that. One of the things I find most, my pleasure. One of the things I find most interesting, and I see that I have a former resident of mine on the line, is that when we take a look, when we provide education, when we take a look at patient care, we always have to be prepared to look for the zebras in the flock. To simply look at something and label something with a diagnosis is probably one of the worst things that we can do in medicine. To be able to open the mind, listen to the patient, listen to the family, it's the best justice that we are actually able to do. And at the end of the day, when we start looking for challenges as opposed to diagnosing something as as an ache or a pain, and let's use Tylenol, let's use ibuprofen, let's get over it. I mean, it's everybody has aches and pains. We need to do better. And we need to be aware of the zebras in order to be able to effectively treat individuals. I'm impressed there are 31 people on the line. That means there are 31 afflicted individuals, 31 family members, 31 people that have hopes, goals, dreams, aspirations. It's an absolute honor to be here. We're going to talk about pain in medical psychiatry. It's not all in our head, and basically taking a look at medical psychiatry and pain management. Some disclosures and conflict of interest as we go along. I have done a fair bit of research, advisory, speaking, Congress funding for a variety of institutions across the way, so I offer that as a caveat. I'm not advocating any particular medication. I'm not advising any particular strategy. Every individual is different, and in order to be ensuring that we get the right medication to the right person at the right time for the right condition, we need to ensure that we have open minds. And the concepts of what we do in EIM is translating some of this evidence-based medicine into evidence-informed decisions. When we take a look at pain, it ripples out. It impacts family. It impacts loved ones. Now there's the pain that, I accidentally spilt something on the couch and my wife is going to have pain and travels out to impact other people. But at the end of the day, we do definitely have this ripple outward effect. In order to treat people effectively, in order to address the patient or individual as a whole, they get better as a whole. What we're going to find tonight, if we just deal with pain, it's not going to help the psyche. If we just help the psyche, it's not going to help the pain. What we need to do is look at that interface between the two areas. And the only way that we're going to be able to do that as patients, as family, as clinicians, is by asking questions. I think questions and education is the best way to be able to empower individuals. And Sir William Osler said it best when he said the best preparation for tomorrow is to do today's work superbly well. If we take a look at individuals on a differential, looking at the connective tissue disorders, taking a look across even the spectrum of Ehlers-Danlos, we need to be aware. We need to be educated. A lot of times the clinicians we go to may not have that level of knowledge. A good clinician is the leading practice that they want to see. And sometimes that starts with us. That starts with us as patients. That starts with us as family. We at the end of the day are the advocates. So what we're going to do and where we're going to go, and I see there are people on from Ireland where it's almost 1 o'clock in the morning. So if my voice drones you off to sleep, I apologize. You won't be the first person I've traumatized and put many students and residents to sleep across my years of medicine. So you're in good hands. Our learning objectives then, so we'll understand medical psychiatry and personalized medicine, the fact that we're all different. We can't take a cookie cutter in the shape of a snowflake and expect it to look like a snowman. It's personalized. We're going to address several options relating to pain management, where it's about empowerment, empowering of clients, family, and clinicians regarding hope. And y'all will figure out what hope means as we go along. We'll appreciate how every person is different in care. And one of the things in one of the other chat groups that I've participated in that seems to be very common, and I'll explain why in EDS it's perhaps more common, is learning about serotonin syndrome and this early awareness and treatment as opposed to the negative outcomes. And at the end of the day, our hope, our goals, our dreams, our objectives is to get the right drug to the right person at the right time for the right condition, balancing and achieving and ensuring a minimum of adverse effects. And that, at the end of the day, requires balancing patient, psychosocial, transmitters, neurotransmitters, medication impact, all addressing the ultimate risk-benefit for the patient and striving to respect and address the patient-specific challenges with respect to specific patient and medical conditions. Same caveats as Mr. Furman. A lot of our references are available on our website. It is a free website. I believe the more information that's disseminated is power, so our website is available there. A lot of the papers that I'm going to cite through the evening is our own original research on serotonin syndrome, for example, pain management. And the legal stuff, exactly the same thing. If y'all are in distress, dial 911, get the medical needs you are looking for, because if you're looking at me providing telemedicine, we don't do very good CPR over the phone. So what happens is that individuals sometimes will appear or feel to be caught between a rock and a hard place. Where subsequently or where do they end up going becomes a question. Now, the CPCCM model is really how we need to be looking at individuals. I can't see people nodding on the screen or anything like that. In 1954, we had this lovely thing called the medical model. And the medical model was all about, well, medicine. If we take a look at moving ahead, in 1976, Dr. George Engel came up with this lovely concept called the biopsychosocial model, which is actually taking a look at an individual from a biological, psychological, and the impact on social status and functionality. Two papers came out at exactly the same time. Our paper from Western University and our colleagues out at University of British Columbia came up with the collaborative patient-centered care model. And the CPCCM model, collaborative patient-centered care model, imagine this, folks. It's about the patient. I know it's sort of a novel concept. But if we actually find out what are your hopes, what are your goals, what are your dreams, what are your aspirations, at the end of the day, where do you want to go? What do you want to do? That helps us then with your input, with your family's input. We can then filter through our own therapeutic thought processes, working in a collaborative model to achieve those objectives. So what is our therapeutic thought process? And I'm a big believer in as much open disclosure as possible, so I'll give you all a bit of a hint in the inside of the clinical mind. And our therapeutic thought process, our root cause analysis. What is medical psychiatry at the end of the day? So our first ingredient, so imagine we're mixing a fine recipe here. It's going to be lovely and edible and all the good things in life. So our first ingredient is our therapeutic thought process. When we do an intervention, because remember now, we know an individual's hopes, their goals, their dreams, their aspirations, what do they want? Well, we go to the next step, which is before we start to use a therapeutic intervention, we filter through this TTP, or therapeutic thought process. And if you are going to be getting an intervention, you want to ask these questions. Number one, is it therapeutic? Meaning, does it make sense? Does it fit in the realm of logic? A is accuracy. If we're going to be using a medication, is it the right dose? As we're going to learn and discuss through the evening, EDS patients may be more susceptible to certain types of medication. For example, those that act on serotonin by virtue of an autoimmune component. A is allergies. I mean, it's a no-brainer. I mean, if you're anaphylactic or develop hives or rash to a medication, we don't want to go there. But there's also chances of cross-allergies. For example, certain stomach medications like metoclopramide, you don't want to take it if you're allergic to Haldol or haloperidol. If you're allergic to tramadol, y'all don't want to take venlafaxine or Effexor at the same time. They are structurally similar. So there's little subtle things that there can be can occur. I is interactions, ensuring that combinations of therapy do not present as a problem. D is duplication. What's the probability somebody's on the same medication multiple times? C is compliance. So staying on the medication, which ties into Mr. Furman's initial concept, which is not to change medications unless there is a particular reason or rationale. Compliance or staying on the medication or an intervention is essential because the body gets used to a medication across time. The body gets used to an intervention across time. So imagine, just as an example, is you're always used to getting $20 in a Christmas card every year, and every year you think, what am I going to do with that $20? I'm going to buy a couple magazines, I'm going to go to Starbucks, and, you get an idea, and every year you're going to want to do this. But what happens if you lose the $20? What happens one year when you get the Christmas card and there's no $20 in it? You open that card, you shake it out, you think somebody must have taped it to the card or the envelope, or they're playing a joke, but there's no $20. You miss it. And the body gets used to it. It develops a degree of tolerance. So what happens is if you stop it, your body notices it, especially if it's immediate. C is consent, ensuring that indeed, as we have the right medication at the right time, what is our involvement in it as individuals? And C is cost. It's not just a matter of the dollars and cents. It's also a matter of what is the long-term impact of this intervention. Anybody that's ever done time with me as a student or resident knows that if we start an intervention, and my student or resident can't tell me within 5 years what's the probability that negative outcomes or positive outcomes are going to happen to the patient, and they proceed with this intervention, then they're going to find themselves somewhere in Canada where the polar bear poop steams out behind the hospital dumpster, which is really far north. The second ingredient is the patient themselves. So ensuring, and this is old literature, the DSM-4 text revision is an old piece of literature. It was actually removed in May of this year for the DSM-5. But I still use the DSM-4 text revision because it gives us a bit of a feeling. It shows that degree of interface between connective tissue disorders, pain, and mental health. Because interestingly, so the Axis 1 disorder is your primary mental health condition. It's bipolar, schizophrenia, depression. Axis 2 is anything that exists in the mental health realm, but is not a primary diagnosis, although it could be. That's substance use disorder, PTSD, anxiety. Axis 3 is your concurrent medical condition. So that would be EDS. That would be pain. That would be cardiovascular complaints, challenges that come from EDS. Axis 4 is your psychosocial stressors, and the psychosocial stressors are the same for almost everybody in the world. It's not a matter of being a mental health patient. It's the same for everybody. And although we call this a patient, although we say it's DSM-4 text revision, it applies to absolutely everybody. So that this concept of Axis 1 through Axis 5. So Axis 4, your psychosocial stressors, when I say everything that sort of causes anxiety, stress, etc. for individuals. Same for basically everybody. Money, job, family, in-laws. I already said that. Well, I meant to say it twice. Axis 5 is your global assessment of functioning, how well you go overall. I see somebody wants to make a gemstone, make a ring out of the gemstone. That actually is the Musharraf red diamond, which comes from India, if anybody's interested, that little factoid. Plus, we need to take a look at patient-specific transmitters and neurotransmitters. So when we start to use a medication, when we take a look at pain, and some of these slides, I give credit and kudos to my colleague, Professor Stovall, on this one. So patient-specific factors are the severity of pain, whether there's drug allergies, concurrent medications, which we'll touch on with serotonin syndrome, polymorphisms. Everybody, if we take a look at medical condition, at concurrent medications, the probability once you're on other medications, it becomes a very large concern. Polypharmacy is pandemic, but we'll touch on that. Medical conditions, some people are more or less sensitive to pain, and it's actually quite rare that people are less sensitive to pain, and the discussions that we're going to have tonight in the interface with mental health is individuals are more prone to develop pain. Polymorphisms, everybody's different. I'm going to teach you how you're different. I'm going to show you how you can identify that you're different, and we won't have to do any genetic testing on you. C is compliance, which we touched on, cost, and then the general thought process. Now, neurotransmission is basically how the pain travels in the body. So if for some reason, and this is lovely because it's being done by WebEx, so that if I put somebody to sleep, they can't kick me. But if somebody was to kick me because I've really annoyed them, what is going to happen is there's going to be a noradrenergic flight or fight reaction that goes right up my leg, goes across my spinal cord, shoots up the dorsal horn, and then what happens is my brain goes, crap, that really hurts. And what happens, in order to mitigate some of that pain, there's a dampening serotonin, and serotonin is that feel-good hormone. So imagine you got that big ring as a piece of jewelry, or imagine you had a really big turkey dinner and you just pass out on the couch, or imagine you got what you wanted for Christmas. What happens is you get all that good serotonin, and that dampening signal actually goes down to dampen some of that signal. Now, in EDS, one of the problems that happen, also with autoimmune conditions, etc., PTSD, acquired brain injury, we'll talk about that, is that serotonin signal becomes dampened, which means y'all don't get the same amount of effect of serotonin. You're not getting to feel good. All you're feeling is just kicking the leg, and like nobody is being able to dampen it. It's like, it's fingernails on a chalkboard sort of thought. That's neurotransmission. Now, there are physical symptoms and psychiatric conditions, which links to one of the Q&As, and there is a Q&A box there for y'all if you want to use it. That overlap between physical and psychiatric is large. Now, we're not talking about psychiatric tonight, but depression is the most common psychiatric symptomatology. The physical symptoms is pain. You can see, like a Gordian knot, it is impossible to be able to just deal with physical and not be able to deal with, psychiatric, because it makes perfect sense. I saw several people said on the chat about EDS-3, the amount of pain, the impact on mobility, the cardiovascular complications, the hypertension, the increased sensitivity, the sleep disturbances. That impacts an individual being able to do what they want to do. It hits individuals when they're in their prime of their life. Of course it's going to cause depression. That's just a given. And so we need to treat the two together effectively in order to control symptoms. The concept is gaslighting. It's a bit of a new age term, and I know it doesn't apply specifically to this, but basically it says one evil propagates another evil. And when you're tired, and if I was to talk at you for the next 3 days and force you to stay awake, remember I work for National Defense, I assure you I can do that. And if we keep you awake for 3 days, eventually what's going to happen is you're going to become fatigued, and you're going to become cranky, and you're going to become unhappy with me, and eventually you're going to become psychotic and want to kill me. That overlap, that depression, those mental health disorders tie in so tightly to pain, to fatigue. Infection. Infection is actually exceedingly interesting if we take a look at it from clinical parameters, because if we take a look at an individual with infection, number one, what happens is your white blood cells go up, your sleep changes, but also what happens is your body releases these neurotransmitters called interleukins. So not exactly neurotransmitters. I'm using the word a little bit loosely, but the interleukin 6 and interleukin 17 are actually linked with triggering cascades of autoimmune reaction. And autoimmune itself, fibromyalgia. I mean, I remember when we first learned about fibromyalgia when I was in school in the 80s. I'm dating myself. But there was a section in the Merck manual which basically said, it's purely psychiatric. It's not real. Thank goodness we now know the rheumatoid factor goes up and there's an autoimmune component. You look at multiple sclerosis, neuromyelitis optica, etc. There's a strong degree of interplay between increased pain sensitivity and mental health. Because there's that shared neuronal pathway. When I get kicked, I'm sending up that flight or fight. Well, what happens if your blood vessels are not that elastic? What happens if you don't have enough serotonin to dampen the pain? When we go and talk to a clinician, we need to be able to reinforce. I have EDS. I'm more prone to feeling this pain. I'm not a drug seeker. Really, I'm not. What I want is a quality of life. Don't you enjoy that? And these shared neurotransmitters that work on pain also work on mental health. Now, there's one more I haven't touched on, and I'll get to it in a couple minutes, and that's dopamine. Dopamine is actually critical, but obviously it wasn't critical enough for me to put on the beginning set of slides. So depression and pain, so there are physical brain changes, so there's neuroplasticity, there's anastomosis. What happens is the brain works around the damaged areas. And what happens when somebody feels depressed? What happens if I don't have adequate pain control? What happens if every time something happens, I feel it, and I'm tired? Well, remember I talked about serotonin, I talked about dopamine. There's a third neurotransmitter. That third neurotransmitter is dopamine. Dopamine is the feel-good hormone. Dopamine is associated with all the good stuff in life. And what it does is it is released when people do things like internet, talking to a good friend, shoe shopping, all the good stuff in life. But what happens is you don't have enough dopamine. Because the serotonin interfaces with dopamine. You don't have serotonin, guess what? You probably don't have dopamine. And from a mental health perspective, that is critical. And why is it critical? Because things happen in life, and if you don't get the pleasure from it, you buy this pair of shoes and you just go, meh, oh well, I guess they're pretty. You know, you sound like Eeyore. And people say, those are great shoes. Those are great shoes. Why aren't you happy? Because it's harder to be. So what people turn to, I'm not having adequate pain control. I have less serotonin. I have less dopamine. And so people turn to other forms of substances. Alcohol, prescription abuse, etc. I've seen it repeated over and over and over, unfortunately, in my clinical practice. And then there is stress and trauma that are associated with it. An overview of receptors, I won't go into any great length, but an astute clinician, in theory, should be able to look at an individual, know what their neurotransmitter imbalances are. And it's really not any different than a diabetic. We shouldn't be anyway. Diabetes, it's an imbalance of a normal hormone called insulin present in all of us that require external medications to re-regulate that hormone to maintain quality and quantity of life when combined with all the good stuff, regular wake, sleep, diet, routine, exercise, somebody to talk to. Well, mental health conditions, it's an imbalance of normal neurotransmitters present in all of us, like 5-HT, like dopamine, like norepinephrine, that require external medications to re-regulate it to maintain quality and quantity of life, when combined with regular wake, sleep, diet, routine, exercise, and somebody to talk to. And so an astute clinician will know which medications to use by virtue of how they work. And then they might slip and say, oh, you know what, if you go for a 1 mile walk, it has about the same effect as 5 milligrams of Ritalin and 10 milligrams of fluoxetine or Prozac. You'll feel better. And you look at them and say, Doc, smack yourself in the head. I can't walk that far. So this is about the balance. This is about having that understanding and being heard. And there are many causes of neurotransmitter imbalances, as stated here. Neurotoxins is very interesting. That's a whole other side discussion relating to viruses and other challenges. This is the big three. I've talked about them already. So anybody who's ever had to hear me speak knows that I say what I say, and then I say that I say it, and then I say that I said it, and then I say what I'm going to say at the end. So basically, you're going to get to hear everything about 4 times if it's of any interest. So norepinephrine, serotonin, dopamine, your big ones. Now, a lot of times what we talk about is serotonin. Excuse me. Now, serotonin, because it's a little bit low, a lot of medications that we use in mental health and pain management have a high impact on serotonin. What happens in an individual, I'm just going to show my cursor here, but what happens, we increase the serotonin, and within a couple of hours, and especially in my experience with autoimmune disorders, individuals have this combination happen. Now, it occurs up to 20%. Some literature says as high as 40%, but this irritability, like a cat on a hot skittle. And what happens, it's a catastrophic combination because that dopamine, which is already depleted, goes down even more. And the best way, this is serotonin syndrome. This is the early way to be able to identify. So if you're on, and I'll talk about it as we get near the end, but medications, all of your antidepressants, with the, actually I was about to say with the exception of a couple, but no, I think actually all of them directly or indirectly act on serotonin in some way, shape, or form. Some pain management medications. Now, it doesn't mean stop the medication. It means have that degree of awareness associated with it. By and large, not going to be a problem. However, some people in personalized medicine that are more sensitive to some types of medication makes a huge difference. And often when we're taking a look and doing workups of patients, I always ask if individuals have had allergies, side effects, or intolerances from medications, because that often will serve as potentially a distant early warning sign for me as well. So what happens, and most of this, very easy to monitor. When you start on a new medication, talk to your family. This paper is available. It's available on that website, eimcare.org. What happens? Your cognition, your ability to think, becomes a little fuzzy. If you have a home blood pressure machine, your heart rate goes up, your blood pressure goes up, and you start to have spasms. That's a horrible word to say to a bunch of people with EDS or family members. So you can imagine how horrible it actually is. You notice spasms, eyelids, normally of the face, what we call neuromuscular reactions that happen, and then progression from there. So serotonin syndrome, it's very rare. I have seen cases of it in my clinical experience. I've treated probably, I'm just thinking, probably at least 24 cases in my clinical experience. It's potentially life-threatening. The youngest patient that passed away was 3 years old that I had seen. It is potentially life-threatening. There are several potential causes, and whether or not it's just normal drug use, whether it's taking too much, and again, I go back to Mr. Furman's advocacy, which is stay on the medication, don't take more, don't take less. If there are any changes, then let the physician know. Because there are inadvertent self-poisoning. If your cognition's impaired, did I take this? No, I didn't take this, well, I'm going to take it again. It happens. And it's preventable. It includes all ages, and more than 85% of clinicians are unaware that serotonin syndrome occurs as a clinical diagnosis. So that becomes very important, because at the end of the day, we become the advocate. And we talked about the triad of clinical changes. So I'll just speak a little clearer, because I see there's a couple of people that my microphone seems a little more muffled, so we'll try this. So these are the triad of clinical changes. So the mild cases through to life-threatening are as listed, and it does exist on a spectrum. So whether or not a person's agitated, activated, etc. Again, it'll be available afterwards. So a biopsychosocial overview of pain, what is it? Well, as we talk about it, it's a reciprocal relationship. Pain and depression have a high degree of interplay with each other, and there's a comorbidity of mental health and physical health. It's well documented, especially in individuals with chronic disease. So it becomes a very vicious cycle. One feeds on the other, and I'll go through a couple pieces of literature that talks about it. It tends to be consistent across cultures. The mental health disorders, which you now know, this makes sense. Mental health disorders are known to be exacerbated by pain. And a predisposition towards a mental health condition can affect the experience of pain and the evolution of a chronic disability. Now that's huge. And the reason why it's huge is the incidence of mental health disorders is on the uprise. Why? And it's very interesting, because if we're to take a look at the incidence of mental health disorders in first world countries, just having a pre-existing underlying condition, the incidence is bipolar 7%, schizophrenia 2%, substance use disorder 17%, if we just rack up depression 25%, we rack up those numbers, it's 50%. So look to the person to the left, look at yourself, it's going to be one of the two of you. That's very, very high, especially when we consider third world countries where you have to live in a hut. You have no running water, you have no computer, you have no electricity, you're living in a hut. You have to walk 5 miles for water. And in that hut, you have your mother-in-law and a goat. And you'd rather talk to the goat. The incidence of mental health disorders is only 2%. So one can imagine the incidence and the severity of pain actually becomes increased across time. And it's a huge cost to society, But what I'm more concerned about is the cost to the individual. Pain in and of itself is 1 in 6 Americans, costing $70 billion. It's a huge amount. That's just without having a connective tissue disorder. And how people present, because remember, we have to be big, we have to be tough, we have to be strong. People normally present with physical symptoms. The depression often goes under-recognized. And that pain cycle, we've talked about it. You start to see how this all comes together. Pain, anxiety affects your sleep. Not sleeping affects your mood. Not having a positive mood affects your activity. Not getting out affects your exercise and energy. And it all goes together. The perception of pain is a couple of scales, whether it be from 0 to 10. You've heard that before along the way. But the perceptions of pain, I think probably one of the best scales is the happy face. So if you hurt, you're sad. If you don't hurt, you're happy. That sort of puts it all together. The consequences of undertreated chronic pain, they're physiological, so cardiovascular. So on top of the fact that norepinephrine we talked about, there are psychological concerns. Because there are serotonin receptors that line everywhere, it affects your gastrointestinal tract. And let me tell you, I have had patients who have become psychotic if they can't take a poop. So if your gastrointestinal tract is not happy, and that's because of changes in serotonin, it becomes an issue. Psychological impact, diminished quality of life, impairment of activities, and there's a huge impact, absenteeism, presenteeism, unemployment, underemployment, etc. That pain becomes more and more, which leads to disability and functional limitations. If I can't do what I want to do, remember our underlying CPCCM model, which is what do you want? That functional limitation leads to anxiety. That anxiety leads to grief. And that's a very interesting interplay, because if I can't do what I wanted, we as clinicians have to be aware that there is going to be a feeling of loss in the individual and in the family. So what symptoms are most resistant? At the end of the day, if we take a look at individuals, some of the hardest things to be able to treat is somatic pain. So soma coming from the body. So that becomes a challenge. And there's a component of physical and emotional. We have to be able to take a look at being able to treat both aspects. Now, Baer et al. Did a wonderful paper talking about pain being the 5th vital sign. This was actually done in the military, taking a look at individuals that had trauma. Now, I bring up trauma in an EDS presentation because remember what I just said about grief? Folks, that's a trauma. And guess what? It makes the depression worse. And guess what? That makes the pain worse. We're going to teach you about empowerment. Probably I'm not going to teach you. Y'all are going to teach me, which makes it even better. And so individuals, if you have severe pain, so the odds ratio, so that's the probability that you're going to get it. If you have severe pain, the probability that you'll develop depression is 12 times that of baseline. So as a clinician, that is exceedingly important to me to be able to treat individuals with severe pain, but also address their mental health issues and be sure to empower the individuals to be able to do what they want to be able to do as much as possible. So the pharmacology, I'll go through some of the medications, but I won't spend any great length of time. This is not a drug talk. This is more about an empowerment talk, so I'd rather spend most of the time at the back end. So we take a look, again, stated to be the 5th vital sign. So the pulse, blood pressure, core temperature, respiration are our 4 vital signs if we take a look at body systems and assessment of a patient. Pain's number 5. It's absolutely critical and integral element. And when we do control pain, we want to ensure it's balanced, using the least invasive route as possible. Now, the World Health Organization has an analgesic ladder, and basically starting from non-opioids, so non-narcotics, and anti-inflammatories up to and including strong narcotics. And everybody's individual as we go along. I will talk about certain pain management, and embedded within the pain management, what I'm going to do is touch on some of the personalized medicine. These are the medications I'm going to very high level touch on. So if we take a look at pain, there are a couple types of pain. There is a body pain or a somatic pain, and then there is a neuropathic pain. Neuropathic pain tends to come from the nerves. So a somatic pain is this ouch, the ache, the just, that feeling of pressure at the site. Neuropathic pain is like putting your finger on a stove. It's shooting, it's burning, it's stabbing, it's stinging, it's throbbing. In EDS, there's the risk of both types of pain. So in neuropathic pain, the medications we tend to turn to are gabapentin, tramadol. We don't use as much gabapentin as we used to. Tricyclics, SNRI, serotonin, norepinephrine reuptake inhibitors. What that means is the amount of serotonin and norepinephrine in the brain is actually increased, and then norepinephrine dopamine agents are increased. Tramadol or Tramacet is a medication that we've used more and more because it's a non-narcotic. It has overlap, and depending which state you're in, it would actually be treated as a narcotic. So it does have similar effects to the mu receptor, which is actually works to help control pain, but it doesn't have the impact on breathing. And again, if there's a problem with lungs contractility, that becomes a very large issue. However, tramadol is structurally related to a drug called Effexor or venlafaxine, which I touched on already. And in the world of personalized medicine, it may be beneficial because it does have an antidepressant activity. But I want to caution, this is personalized medicine. And it's why we can't use a cookie-cutter approach. And why we can't use a cookie-cutter approach is because individuals are going to react to medications differently. The reason why is I always assume clinically with patients that 1 in 6 of my Caucasian patients are not going to react to my tramadol the way I expect. It is important for me to remember because tramadol is broken down in the body to an active drug. 8% of people don't make that active drug. 8% of people make too much of it. So we start low. Absolutely essential in EDS because if there is sensitivity to serotonin, higher doses are more prone to have negative outcomes. And if you're one of those 8%, I don't want you experiencing muscle spasms. To cause harm to a patient, the worst thing I can do. So this is the personalized medication. It's similar to venlafaxine, and there are different, I won't go into the 2D6 or I won't go into the polymorphisms or the way people work, but everybody is slightly different. And sometimes as well, and this is a study and it's actually available on the EIM webpage as well, is it can actually cause individuals to rev up and cycle a little bit quicker. SNRIs, or duloxetine, venlafaxines of the world, are used, especially duloxetine, for neuropathic pain. It has an indication for fibromyalgia, and it's a potent inhibitor. It actually increases the amount of serotonin available. It modulates mood and has effect in depression and anxiety. So if we actually consider, excuse me, remember why we said about substance abuse? People aren't feeling the same. They aren't feeling as good. They turn to something else. Well, what happens if I smoke? Smoking becomes a very large issue. This is another question to ask. If I smoke, will it impact the medication? Because if I take duloxetine or Cymbalta, it's going to become less effective. which means you're not going to have as much pain relief, which means you're still going to have the impact on mood. So that becomes yet another issue as well. Gabapentin is related to our normal sleep hormone and our relax hormone, which is GABA, and it also has analgesic properties as well. Pregabalin is a new product that's come out since gabapentin has come out. I won't go into anything in any great length, but suffice to say a lot of these medications started their life as anticonvulsants or anti-seizure medications, because what they do is stabilize the brain and help prevent some of these extra firings that happen. Tricyclics, if we're taking a look at the tricyclics, we don't use them as much as we used to because of cardiovascular concerns at much higher doses than what we talk about in pain management. But that's amitriptyline and nortriptyline, and they also will help with mood and anxiety, although we may tend to need higher doses. There is a potential for drug interactions as well, and so that's one of the things. Become friends with your physician, become friends with your pharmacist, ask the question. That becomes absolutely huge. All of these medications I'm talking about exist within the realm of mental health and psychiatry. Bupropion, it's a relatively new agent. There aren't a huge amount of studies available for it. It's also known as Zyban, as an anti-smoking agent. But that dopamine tends to give individuals some ability of pain management. And you guys are pros at this right now, right? We talked about this. If you drop down dopamine, what happens? You feel pain more. You don't feel pleasure. So if we can increase the dopamine, what happens is it gives individuals potentially beneficial effects and pain management. That's some of the theory and from the noradrenergic or norepinephrine component of it. However, all these medications aren't for everybody. This whole personalized medicine, if anybody on the line is Han Chinese, don't take bupropion because you won't be able to break it down. And if you don't break it down, what happens is it builds up. And if it builds up, you end up with seizures. The risk of seizures is 1 in 3,000, or even worse is if the dose builds up too high, and I've had a patient with this, is develop an ICH, or intracerebral hemorrhage, and that was a fatality that I ended up reporting to Health Canada. So norepinephrine, dopamine, again, there's conflicting evidence. There's not a lot of information available at this particular point in time. I want to spend the last bit of time on what really matters, which is non-pharmacological therapies. Non-pharmacological therapies help reduce both anxiety and pain in child and adults, the need for additional analgesics and potential drug-induced side effects. For pain management, there are physical therapies, so ice, heat, depending whether it's a recent or later on injury. Hydration, keeping yourself well hydrated, absolutely incredible what happens. The other great thing is, too, is if your kidneys are working fine, it helps clear through the medication, especially if the medication loves water. Positioning, where you sit, how you do. You guys are pros at this. You could teach me in order to ensure that there is comfort. Exercise. I don't expect you to jog the Boston Marathon. I can't even make it up the stairs someday, so I'm not going to ask you to do the Boston Marathon. But exercise is absolutely critical because it gives you what I talked about. It gives you some of that beneficial effect. And if you're going to do exercise, folks, do it outside. The reason why doing it outside is so absolutely critical is because the sun is going to give you, for most of the year, unless we have a winter like we had last year here in Canada, it's going to give you vitamin D. And if you give vitamin D, it serves as an antioxidant. If it serves as an antioxidant, it helps get rid of some of these autoimmune components. Lovely. Get outside. Massage therapy. Again, having an individual that knows about EDS. I don't want some Swedish person named Olga working on me. It's going to hurt. So this becomes another issue as well. There are psychological therapies that we look at, education, distraction therapy, relaxation, deep breathing. Deep breathing is wonderful. Cognitive behavioral therapy, I'll talk a little bit more about that, and art therapy. Other alternative therapies, I'm a big believer in mindfulness. So mindfulness is actually being at one. When I teach first-year medicine, I teach first-year medical students how to become good doctors. And one of the things we do is we put an apple in the middle of the table, and I ask them, what do they see? They look at me like I've just done crack, as if I've been Mayor Rob Ford, Mayor of the City of Toronto, and like, what is wrong with this guy? Because they see an apple. And then I tell them, what do you see? I say, congratulations, whoever saw an apple, you've just become the new chief of medicine. However, what do you see? And then people start seeing the color, the texture, the vitality. Then I go one step further and say, what is that apple made of? And it's full of all sorts of non-apple elements. And then I ask them the question, when was the last time you ever looked at an apple like that? Something we need to do. Another exercise that works great for mindfulness is when I first start to have students in residence, I have them sit under a tree and do absolutely nothing for an hour. They think, oh, this guy is great. He's the second coming. I don't have to do 500 pages of cardiology. They sit under the tree, and for the first 5 minutes, the tree's digging in their back. They're uncomfortable. Their mind is going, I could be doing this, I could be doing that. Well, now they know how my bipolar patient feels. Then they sit there for a while longer and think, I could get up. He wouldn't know. Would he know? Well, now they know how my paranoid and anxious patient feels. And if they can survive to about 45 minutes, colors become clearer. Sounds become sharper. Those are the people I want working on my patients. And that's one of the things that we actually start to do. I see a comment about pool therapy. Absolutely. Hydration and the resistance that occurs in a pool when you remove the resistance of air allows the body to move freely. Hydrotherapy and being able to exercise the muscles. Absolutely. Thank you for that, Megan. Meditation. Meditation is huge. I try to meditate every night. Meditation helps provide positive moods, gives self-efficacy, helps remove some anxiety, serves as a distraction. Acupuncture, I'm not as much of a fan of it, but that's just my personal experience. I don't have a huge amount of knowledge, so I will say that right up front. So it's a recognized benefit for pain by the World Health Organization. Somebody's made the comment about TENS, transelectrical neurostimulation. That as well works through the same sort of concepts in stimulation of the nerves in order to be able to release the neurotransmitters. It works the same sort of concept as acupuncture, because if you work specifically at that site, what happens is the nerves will actually release these neurotransmitters, and if they actually release the neurotransmitters, it actually produces further down the pipeline endorphins. Endorphins are their actual aspect of, it's almost like a narcotic to be able to relieve pain aspects. Excuse me. And because most of the acupoints are actually near the nerves, and tends to help with a lot of variety of types of pains. Massage therapy, I'm not talking about going to the sort of massage therapy that involves a red light district somewhere in New York City. I'm talking about the sort of massage therapy that is therapeutic, which becomes very beneficial for individuals to help loosen up some of the massages, etc. It helps reduce stress, relieve tension by enhancing blood flow, and helps reduce some of the presences of substances that generate and sustain pain. One of the biggest ones being is if your muscles aren't working or if your muscles are in overdrive, it produces this thing called lactic acid. Same sort of thing as what's called getting a stitch in your side. except it's actually even more severe. One of the questions is about prolotherapy, and I don't have any experience with that to be able to answer. There are other experiences or other studies that we're taking a look at. So one is we're looking at a PTSD study right now, which is called the Alois study, and taking a look at individuals and being able to get them out and rejuvenate, regenerate, and help remove some imprinting, basically help jettison some of the luggage from the plane. Talk therapy, very therapeutic. There's actually a new paper that was just published today, actually. It came out on talk therapy and exactly how beneficial it truly was. Yoga, if possible. Again, I don't expect you to be able to bend into a pretzel and give yourself a rectal self-examination. What we want to be able to do with yoga is just to be able to stretch some of the muscles. CBT is cognitive behavioral therapy. DBT is, so that's cognitive behavioral therapy, is having an awareness of the situation. Dialectical behavioral therapy, or DBT, is being able to talk through it. IPT is interpersonal therapy and how what we do interacts with others. I'm a big believer personally of play therapy and just being a bit of a kid at heart, and having a bit of a laugh is a bit of a joke, is a bit of a stress reliever. And if anybody thinks about the movie with Robin Williams and Patch Adams, and then ITAP is a concept that we're taking a look at, a collaboration for the fourth quarter of this year. Alois is currently being underwritten as we speak. So, in conclusion, what we want to take a look at is we want to be prescribers of hope. As clinicians, I just had to smile. Someone likes shoe buying therapy. Oh, I love you people. This is great. Hope is, H is holistic. If we want to do therapies, we want to ensure that they are well-rounded. They are holistic. We want to ensure that they are outcome-driven. We want to know at the end of the day, what are our goals? The expression is, it's better to aim for the stars and miss than to aim for a pile of poop and hit it. So we want goals. We want objectives. It's easy to change the vector along the way to hit those objectives. It has to be personalized. What we use for a particular individual. We talked about some of the personalized medicine. We talked about the cookie cutter. And most important of all is empowerment. Knowing what questions to ask and when to ask them is absolutely key. Give some references along the way. These are some of the papers that we've done on serotonin syndrome, and some of the case examples that we've had. Some of these are, actually I think most of these are available in the public domain. And the other paper that talked about serotonin syndrome, sort of the guru, is Dr. Boyer. And his paper from 2005 that was published, excuse me, in the New England Journal of Medicine is Landmark. And then some work as well on occupational musculoskeletal disorders. So that sort of brings a bit of an overview to where we are. And, excuse me, I'm just going to muffle myself here. Just because otherwise, I mean, I can talk at you for 3 days and keep you up. I don't necessarily know whether or not my voice always will. Okay, I'll take my first breath and I'll go to the Q&A. So definitely please, oh, Deanna's already done it for me. You are like a Greek goddess, Deanna, and you've already got the information. Definitely,
no
we have this.
I'm here to help if you need me.
Excellent, thank you. Handle any questions and answers. I will be absolutely the first person to say if I don't have the answer or if I don't know that I don't know, but I can look into it, and we will ensure that the questions are read, and I'll just mention first names. The goal is not to provide medical advice or diagnose you. It's about as effective as me providing CPR over the phone, which isn't that effective. So the first question is from Lisa, and I had the opportunity to see this question before the presentation started, and I just look at it and go, wow, I wish medical students and residents ask questions the same way, which is, the question is, do our bodies differentiate, distinguish, or understand the difference between unresolved mental pain and chronic acute physical pain? How so? Please explain. For example, a patient suffers from PTSD and EDS. Well, at the end of the day, they are rooted in different areas. So mental pain is actually derived from the mind. Chronic acute physical pain goes from the body. Saying that, though, they all get processed through exactly the same area. And where the body processes the information is centrally, which means in the brain. And this physical acute pain occurs two ways. One is a physical somatic pain, and the other is a neurotransmitter or neuropathic, that sharp shooting pain. So how an individual, how do the bodies differentiate it? They actually really don't. What the easiest way to compare it, or the easy way to analyze it, is unresolved mental pain. We can't differentiate that is different from chronic acute physical pain. What happens, and what we use, or what I use as a clinical trigger, is if we use appropriate forms of pharmacotherapy or non-pharmacological treatments, and the individual still isn't getting better. That may actually give us some idea that it is an unresolved mental pain as well as there, especially taking a look at an individual's history. The other component is suffering from PTSD as well. PTSD is very interesting because it actually causes almost like an intracerebral block. Within the brain. It causes a lesion in the brain, and what happens is the body has to create a detour around it. So imagine in the United States, I-75 is blocked with a multi-vehicle accident. Y'all are going to have to go through country roads in order to be able to detour around that accident. That block on I-75 is your PTSD. It's the trauma. It's a physical trauma. And what happens is our bodies go around some of that fertile secondary roads, and it's not equipped to deal with I-75 traffic. What then happens is an individual becomes more sensitive. And if they become more sensitive, they tend to feel pain more, which you start to see, again, that interplay between the two. So that sort of gives a little bit of an overview. The next question from Kay, which is talking about dopamine, which is suspected being early onset Parkinson's disease, being put on ropinirole, 0.5 milligram twice a day, which made the individual very ill. Sensitive to medication, most time take the least bit of dosage to avoid side effects, and some of the concerns about Parkinson's disease. But as an individual with hypermobile EDS, should I approach this possible diagnosis, or how should I approach this possible diagnosis and take appropriate action? It's a beautiful question, because once we start putting all of these factors in together, it makes sense an individual has low dopamine. We talked about that. We talked about the shoe shopping. Parkinson's is low dopamine. So the question is, in my mind, is this truly early onset Parkinson's, or is this a manifestation of the EDS? I would actually wonder whether or not it's an EDS component, and it would make a lot of sense that giving more dopamine externally would potentially cause side effects, nausea, vomiting, problems with muscles, etc. My suggestion would be to take a look in a search and try to find out ways to be able to light up or trigger the dopamine internally. Now, this is entirely non-pharmacological, and it's going to be an interesting way of approaching it. But my answer is to Kay, just do what you want. Do what makes you happy. Do it as best as you can. Get the pleasure from it. If you collect something and you love that collection, look at it. Embrace it. That lights up dopamine. And that's how I would first try it. And that may help without going to the aspect of the medications. A question from Barbara. You guys are great at questions. I'm just like watching the things to tick up in the box here. I have chronic migraines with EDS. I take Maxalt, which makes me stupid for a whole day. Is this typical? So Maxalt is an agent that helps increase serotonin. And if an agent increases serotonin, remember what we talked about? You increase serotonin, you can have muscular spasms because you're more sensitive. It could cause muscular spasms. It could cause increases in blood pressure, but even more importantly, it causes cognitive changes. So that feeling stupid makes a lot of sense. It would be dose dependent. So perhaps a lower dose would be able to be effective, and certainly I know that the lowest dose is 5 or 10 milligrams, if I remember off the top of my head. And they come in a tablet that's a wafer. Just break it in half or break it in quarter. It probably will be enough to help with the migraine, but not enough to markedly increase that serotonin. And you'll notice that serotonin increases within about 2 hours. So it's relatively quick. Sue asked the question, any suggestions finding a doctor who thinks like you? Oh, you are the sweetest, Sue. I love you. Who thinks like you in Oakville, Ontario. Each individual has their own thought process, and I don't have any really good recommendations, unfortunately. It's a matter of asking the question of a clinician as to, what are your goals of therapy? Because if their goal of therapy is to find out what your needs are, then I'd be happy with that clinician. I've lost my inbox.
Okay, I can give you the next question.
Okay, I'm still live, but okay.
Okay, do you need me to read that, or do you have it back?
Let's find out here. Let me retry this puppy.
Okay.
You can read it while I'm typing.
Okay. I have a question from Scarlett. I'm not sure if this is in the same order as your questions appear, but she asks, my pain management doctor tried hydromorphone and roxicodone with neither alleviating the debilitating pain that has worsened to the point of being bedridden after her cervical fusion. Mm-hmm. After trying these two, he said if these helped, then no opiate medications would. Do you agree with his assessment?
Well, it's a fairly aggressive combination of medication. Hydromorphone, by and large, tends to be quite effective. But saying that, what happens is across time is individuals develop a degree of tolerance to the medication, and as such, it becomes less effective. And so sometimes individuals will benefit from a rotation of medication. To say that there is nothing else is sort of a little disheartening to me, because there's always something else. And it may be a matter of augmentation. It may be a matter of combining medication. Cervical surgery in and of itself is extremely painful. The other aspect, which links into an area that we've been looking at, is the impact. If you take a look at the cervical surgery and the impact on the pineal gland, that's a whole other discussion, because that links into other attributes. I mean, this is a whole separate side discussion on psionics, which I don't go into. Because we need to be able to turn our head on that. I would personally, if that was me, look at rotating narcotic therapy as one particular option, switching to an agent that has a different receptor, combining medications, using medications of a different class, augmentation using non-pharmacotherapy. So that's, I mean, it's not an ideal answer without knowing the individual, but those would sort of be the initial steps that I would do. I'm back in the session. I have good news and bad news. The good news is I'm back. Well, maybe not. The bad news is I have no Q&A. So Deanna, I'm gonna have to.
No problem. I can catch you up there.
Okay.
Next question is from Catherine, and she asks, how do you objectively measure levels of serotonin, norepinephrine, and dopamine?
Beautiful question. We can't. I'd love to be able to say that we're able to, but we are unable to. It's certainly been tried to be studied. One of the problems, though, when we actually try to study it is we don't have any good markers. If we try to check it through blood or we try to check it through urine, there's so many confounders that it doesn't actually give us a true sign. What we need to actually be able to do is take a look at it from a brain perspective, which we're actually unable to get those levels. The only way we can get a little bit of a feel, and it's very hard to access, is called an fMRI, or a functional MRI, magnetic resonance imaging, to be able to, and we will radio label or provide serotonin externally. We'll radio label it with a nuclear isotope and be able to see what the uptake is.
Okay. And ready for the next question?
Yep.
This is from Donna, and Donna asks, how do you feel about topical pain meds and their efficacy for EDSers pain? For example, compounded prescriptions, topical NSAIDs, etc.
So, again, another good question. I almost feel like I'm doing my examining boards here. You guys are good. I've got that student sweat going on here. So it depends on the product. If we take a look, the compounded products often use diclofenac, which is a non-steroidal anti-inflammatory product. Those non-steroidal products may not penetrate through the skin, but there is a compound that they use in an agent that they use in compounding called PLO gel. That PLO gel, what it does is it allows the medication to be provided directly to the point of need. And it's been done with other medications, doxepin, amitriptyline being a couple of other medications. And two reasons why they tend to have a degree of efficacy. Excuse me. Number one is the medication themselves. And the other aspect as to why these medications tend to work is the simple massaging of the medication into the afflicted area tends to make an individual feel better. So I definitely think it is beneficial. There are some caveats. So some agents have a high amount of methyl salicylate in them. Methyl salicylate actually is a counter-irritant. And basically it will not have any penetrating effect. It's just going to irritate your skin so that you don't, it irritates the skin so you don't have you don't feel the irritation deeper down. So again, it's a matter of taking a look and finding out what is the product. So is it therapeutic? Does it make sense? And then asking the next step, which is, will it penetrate to be able to be effective?
Okay. The next question is from Kay, and she says she's done research concerning alternatives to medication for Parkinson's disease. Many websites speak of fava beans as an alternative to medication. One contraindication to taking dopamine is G6PD deficiency. From what the National Parkinson's Foundation website says, this deficiency is rare, occurring mostly among people of Mediterranean, African, Southeast Asian descent, but others can be affected as well. That was a quote. She asks, would patients with EDS be one of those groups of people that are affected with G6PD deficiency?
Oh, I do not know that answer off the top of my head. That's when I will, if you can bank that one and send it to me, Deanna, that's something that we can work offline. I don't know. I mean, I'll still come up with an answer, not off the top of my head. However, I'll offer the caveat that once we tend to have some degree of genetic mutation, it's not a surprise that we tend to find another one. And certainly G6PD deficiency is rare. It does tend to have a Mideastern centric population. That's that personalized medicine. But it brings up an even more critical teaching point, which is sometimes the medications that we tend to use that are herbals. Almost everything that we use in pharmacy has a herbal root or an herbal origin associated with it. And always asking that question first is key. If you don't have the G6PD gene, what happens is the ability to break down the medication doesn't happen, and in fact can potentially become toxic and life-threatening. I'm just trying to think, and I've probably seen less than a half dozen cases in my 25-year career.
Okay. This question from LB, is there a way to distinguish between physical and mental pain, and does it matter?
Not a huge ability to differentiate between the two. Does it matter is a very interesting question. We can treat the physical pain. I'm just rephrasing the first question, but the physical pain exists within the physical realm. If you go back and take a look at one of the slides, it was the red color. The psychological was the blue, if I remember right, and it has to do with the anxiety, the depression, etc. Where it becomes fuzzy is that overlap area. And if we just treat mental pain, and how do we differentiate mental pain? It's often, we use the criterion with the DSM-4 text revision or the DSM-5. Mental pain often is manifest as neurobehavioral components, such as, I don't feel pleasure. I'm having problems sleeping. My appetite has changed. So all of these become very valuable questions. However, it also overlaps with the pain, the physical pain, which causes problems in sleeping, problems in appetite, problems in mobility. So you can start to see how those two overlap so well with each other. So I don't really have a good set answer as to how we're able to differentiate between the two. One actually, I say, fits the neuropsychiatric components, and one suits the physical, somatic, dull, achy, or neuropathic, sharp, stabbing pain. So that's how we differentiate between the two. However, then the treatment becomes a combination of pharmacological and non-pharmacological aspects. I see that I am back online, so I don't even know where we are, but I'll let you keep reading.
Okay, I can keep reading.
Okay.
This one is again along the same lines, distinguishing where the pain is coming from. Brenda asks, is phantom pain neurological or psychological in nature? Wow, that's a good question. The answer to that is yes, because in true psychiatric answer, the answer to that is yes. And the reason for that being is there is a neurologic component to the pain, because what happens is the nerves that are lost with that limb, or whether the limb goes offline, etc., are still often, the endings are still there in wherever the stump is. But there's also a very large psychological component to it, which makes that neuropathic pain even worse, because there is the grief reaction. It's feeling that the limb should be there. There is the change of mobility or decrease in mobility. And then that goes into grief.
grief becomes a huge issue because grief actually is like a sensitizer, and it's like holding the times button down on a calculator that make individuals feel like instead of saying 6 times 6 equals 36, you get 6 times 6 equals 6,284. Things become even more pronounced with grief, and that phantom pain becomes very, very real. So it's a combination of the two together, in my experience. I didn't have a lot of experience in psychiatry, but I certainly did in medical surgical ICU and orthopedics, which is where I started.
Okay. Elaine makes a comment and wonders if you have any thoughts or reaction to it. She says that it's hard for her to know when the pain is something she should react to and seek help, or when to acknowledge that it's chronic in nature and not needing to be checked out, so to speak.
My first reaction is, because I was allowed to offer my reaction, so I'll offer my reaction. My first reaction is that nobody should be in pain. And the answer as to what defines pain depends on the individual. And how I define pain is unmanageable if an individual is unable to do the activities that they wish to be able to do. If through non-pharmacological methods I'm able to ameliorate or decrease that pain, then I think it's worth approaching. Chronic pain in and of itself is a whole other discussion, because chronic pain in and of itself can be very demotivating, very demoralizing, basically every sort of D word that you can imagine. So I, again, try to find ways to be able to link up with people who have been through similar experiences. And beyond what I had in the presentation, hydrotherapy was brought up, which is a brilliant way to be able to provide some degree of non-resistant exercise. Chronic pain, I didn't go into isometrics tonight. Isometrics is a fascinating study in being able to use the body's muscles against each other to be able to provide exercise and decrease pain and decrease strain. The easy way to do the leg exercises using isometrics, and respecting that I'm not a physiotherapist, is to take a leg against some very solid object. Your spouse, if they've really pissed you off, is also very effective, and push hard against it, or as hard as you're comfortably able to do. And then what happens is that actually gives a degree of resistance exercise to the muscle. The other way that I like to deal with chronic pain is, we talked about acupuncture. I touched on EFT tonight, which is the tapping at the acupuncture points, talking about play therapy, ways to be able to help reinforce the normal neurotransmitters, which help reinforce some of that serotonergic signal.
Okay. The next question is from Karen. She says that she wants to know if there's a drug interaction problem with taking tramadol while on Effexor.
The answer is it depends. It depends on the dose. So one of the issues with the dose is Effexor at very high doses, and when I'm talking high doses, I mean over 225 to 300 milligrams a day. It has a huge amount of serotonin release. It's truly at that high dose an SNDRI, serotonin, norepinephrine, dopamine agent. And tramadol is an SNRI, and if you remember some of the mnemonic, that TAIDCC, D is duplication. So there isn't necessarily, do I have a red flag? No, but I have a yellow flag, and the reason why I have a yellow flag is it is increasing that serotonin. So an individual that had tramadol and Effexor by itself, I'm going to have some caution, and I would probably be educating the individual. When you go to your pharmacy, check your blood pressure. If you notice your heart rate going up a couple of hours after the dose, and you might want to talk to the doc. It's not critical, but hey, it's early to bring it. It's good to bring it up early. If you take the medication, you find that you're confused or stupid, as you see yourself, you're not mentally functioning clearly, then it would be worth bringing it back up to the physician. A rule of thumb that I always tell clinicians when we're taking a look at serotonergic agents is that if you're combining 3 or more serotonergic agents, that risk goes up. Now, when we add in a confounder like EDS or PTSD, I don't know if that 3 parameter still holds. So in the interest of good patient care, I would be educating, monitor the blood pressure, watch for confusion, watch for problems in memory, and most importantly, if you have any spasms, especially in the face or cheek or eyelid, then it could be serotonergic mediated.
Okay.
Like I say, you guys are asking questions I wish medical residents asked.
We have a very informed patient group here.
No kidding.
Okay. And the next one is also related to tramadol. She says, I suffer from mast cell activation disorder with her EDS and has developed allergies to many medications, including all NSAIDs and tramadol. Do you have any suggestions for what might work given my chemical sensitivities?
Mast cell activation disorder. Again, fairly rare, but it certainly can happen at the same time. We talked about that cascade earlier on. One of the concerns that happen is that huge release of cytokines that basically go into flight or fight mode, and the allergies, the histamine release, the facial flushing, the problems breathing, the respiratory problems, all NSAIDs and tramadol. I would be interested in noticing, is it the narcotic component of the tramadol or the effexor-related component of the tramadol? That would then delineate my next line of thinking. If it was the narcotic component, it limits what we're able to use. We're maybe able to use topical or non-pharmacological agents. In most cases, it would not be the narcotic component, which would leave most of the opiates available in the therapeutic arsenal. And then we would go back to the pain ladder for the WHO and take a look at augmentation strategies, and augmentation with Tylenol plus a narcotic plus non-pharmacological therapies would probably be the way that I would go. The other option is depending on the severity of the allergy. This would be very last ditch and this would not be first line, but the way I think is that I always prepare for any contingency. If anybody remembers the miracle of the Hudson and Captain Sullenberger landing the plane on the Hudson River, it's the way I like to think. Captain Sullenberger actually conceptualized what would happen if he's flying over an American city and he goes dead stick. He mentally conceptualized what he would do in his head. And then, son of a gun, what happens is he gets 10 pounds of prime Canada Goose sucked into each of his jet engines, went dead stick, and he was able to carry it through. So if we're able to start conceptualizing this earlier, so much the better. If we're able to use medications, whether it be of steroid nature, if it's a very, very mild allergy, if we have no other options, if we're able to use a steroid, like a glucocorticoid, plus or minus a small amount of diphenhydramine, if that will stabilize the mast cell sufficiently to be able to use the medications if we have nothing else available in our arsenal. Great question.
Okay. Another question related to tramadol. Catherine asks if tramadol is okay with Celexa and gabapentin.
So Celexa is a very potent SSRI, serotonin selective reuptake inhibitor, that increases serotonin. Tramadol increases serotonin. So I go back to that 2-drug warning. I would do the same education, monitor for blood pressure. The combination is usually extremely effective to be able to help control pain. tramadol is a very, very good medication in this particular patient group because it helps satisfy that overlap between the area to be able to help control pain and at the same time help control mood. So I'm pro tramadol in that particular aspect. Once we start combining it, this is where education becomes very much a concern. So the blood pressure, the muscle spasms, the heart rate, the confusion, those would become the big issues. The teaching point that comes out of this is, which goes back to the fava beans, is if you still feel that you're depressed or you've heard from somebody or you read it on Dr. Google in the internet and you want to try St. John's wort, please don't go there because St. John's wort is a very potent antidepressant, lovely herbal, works great, but in that particular situation, because it's such a potent serotonergic promoting agent, that tips you into the 3 or more medications potentially.
Okay. And in a separate entry, Catherine asks about DMSO, and I'm not sure, there's not really a complete question here, so I don't know if you have any thoughts on DMSO.
Not a huge amount. Dimethyl sulfoxide, we don't use it very much. Gosh, I'm just trying to think. The amount of times I've used DMSO clinically, no more than a couple of times that I can think of. And for this particular case, and for this particular example, I honestly can't answer.
Okay. Steve wants to know if there's a blood test that can tell if you are experiencing serotonin syndrome.
Oh, I'd love if I can figure that out, I can retire again. The answer is no. It's entirely based on clinical hallmarks. And if there's any concern, I strongly urge anybody, if there's any questions, the paper that is on the eim-care.org webpage goes into serotonin syndrome in loving depth in a way that's not too threatening or not too scary. And it's a matter of having this awareness. To put serotonin syndrome in perspective, the last year they collected data in the United States, there are 8,187 cases of serotonin syndrome. So it is still quite rare, but I do believe it exists on a spectrum. And again, talking about the miracle of the Hudson, I would much rather be able to analyze and catch it early on than further down the pipeline, where we start to have marked neurocognitive changes. And then further down the pipeline is, potentially even more catastrophic.
Okay. I have another question, rather long, talking about serotonin syndrome. I'll try to paraphrase where I can. Lucinda asks, she has had an experience recently that she thinks may have been serotonin syndrome. It started with muscle spasms and built to a point that she was having random muscle contractions, spasms, sweating profusely, could not talk correctly, swallow easily, spit saliva out. If she sat really still, it would cut down on the spasms, but if she moved even a finger or toe, all her muscles would contract in spasms. Sometimes they were rapid. Also affected her balance. When it finally stopped, she was exhausted and sore and really sick for 5 or 6 days with weakness, malaise, disequilibrium. The nurse assigned to her room told her friend it was an anxiety attack. But when she ran a cross-check on the meds she was taking in the hospital, it came up with a potential of serotonin syndrome. She wonders if she's on the right track. She has a high incident of adverse reactions to meds, including severe neurotoxic reaction to quinolone.
Quinolone, yep.
Quinolones. She wants to avoid this happening again. Wondered if you had any thoughts on that experience she had.
I would say it's enough on my radar. I would, if we take a look at things and labeling it friend or foe, I would label it as a foe. That it is a high enough probability in my mind that I wouldn't in any way, shape, or form want to play that game again. Especially that's something that sounds so potentially devastating and scary, and even more discerning is debilitating, is I probably, in that particular case, if I was going to be using a serotonergic agent, I wouldn't use more than 2, and I would use the lowest doses possible. I had a case in Wisconsin that I consulted on who had severe serotonin syndrome with this muscular spasms, actually having complete jerking and tetany, it's a medical term, of her body, and it could be precipitated even by the smallest amount of serotonin and that degree of sensitivity. In fact, in that particular patient, we even had to get her off of red licorice.
The next question was from Shona, and Shona asks, the question, just a moment here. I'm sorry, I have to go back to that. When taking a lot of pain medicine, is there a way that she can protect her liver?
Oh, gosh, again, another great question. First off, you want to find out, and you can search it. You can find a clinician that you're comfortable with and ask them how much of that medication is processed through the liver. The liver is an extremely forgiving organ. It's probably the most forgiving organ in our body. We can actually take an individual's liver, cut 50% out of it, and it will actually regrow. Individuals can have liver function tests 4 times upper limit of normal before we notice any clinical problems. So the liver is something that doesn't normally get me extremely concerned. If they're on a medication that's processed through the liver, we do LFTs or liver function tests depending on the medication. I normally recommend every 6 months at the outside, and we check ALT, AST, gamma GT are the most common lab results that we'll check. And they're measured against baseline. If they start to creep up, it becomes a problem. If people want to treat or people want to protect their liver, there is an herbal product. You do want to check to make sure, ask your pharmacist or do the research, making sure that there's not any drug interaction, and it's called milk thistle. And it's a medication that I've often recommended to individuals to be able to help ensure healthy hepatic or liver functionality. And the normal dose that we end up using is, you're going to touch me off the top of my head, 150 milligrams twice a day. And that's, when we use an herbal, we want to make sure it's standardized. With milk thistle, in the particular case, the active ingredient is called Silmarian, and we want to make sure it's standardized to 60% Silmarian extract content. Oh, I really do feel I'm writing my medical boards here.
Okay, we have another question. I don't know if this is in your wheelhouse. It's more of a GI question, but I'll mention it anyhow. One of the attendees has a hard time digesting solid foods, and she finds that she has to do soup, yogurt, and smoothies, etc. Her doctors do not seem to be very concerned with it. Should she look more into this, or is this just another EDS problem? I'm wondering perhaps about gastroparesis or something like that, or perhaps just a lot of us have a hard time digesting, it seems like. But I know you're not a GI doctor, so.
Yeah, no, I don't do GI. Where I get concern about, and because again, we're talking about that serotonin, we're talking about serotonin lining the gut, and remember what I said is the gastroparesis, the not being able to move along, the hardening of the intestines, the inability to contract. I mean, that's a combination of serotonin and EDS in my experience. I've certainly done work and published papers on ulcerative colitis and Crohn's and their interface between mental health and depression. Where I would be concerned in asking the question is, although there are certainly some medications that we can use that are prokinetic in nature to be able to move along the gastrointestinal tract, but again, I try to avoid using medications where at all possible. I'm actually, despite my training, relatively anti-pharmacy, and I prefer to use non-pharmacological measures where at all possible. is taking a look at how much of that is actually being absorbed for the diet possible. You know, how many calories are needed? What is the degree of activity? If the activity is low, we can get by on a 1,500 calorie diet. If we're getting on a 1,500 calorie diet, where I get concerned, and again, it's not GI, it's more endocrine, is my magnesium being absorbed? Is my phosphate being absorbed? Is my calcium being absorbed? Are the nutrients actually there and being absorbed? Because if we don't get enough magnesium, what happens is the body starts to develop tetany, which is muscular spasms, which in an EDS discussion makes my heart go pitter-patter, and I really don't like when my heart goes pitter-patter. It means I need a cardiologist. So we need to just ensure, and the way to be able to do that is just a simple blood panel. We do not a CBC differential, but we do an electrolyte panel. An electrolyte panel, we can tell sodium, magnesium, potassium. Potassium is huge. Your potassium goes too low, your heart can go into irregular rhythms. Phosphate, calcium, those are some of the chloride. Those are the big ones on an electrolyte panel. Great question.
Okay. I'm not sure if this question was asked. I'm going back to the point at which I started the Q&A, transitioned over from yours. Did you answer this question about SNRIs that are not recommended for patients with hyperadrenergic POTS? That they've read that SNRIs aren't recommended?
No, we haven't had that discussion.
Okay.
Although SNRIs are noradrenergic in nature, and we talk about that noradrenergic signal being the one that actually stimulates the pain, noradrenergic system works differently centrally versus peripherally. So if we're giving a medication and the central effects are stimulating norepinephrine, I'm actually okay because norepinephrine in the body is metabolized to dopamine. So I'm actually okay with that centrally. And that's one of the reasons why there's a very small body of evidence with Effexor being used for pain management. Even more importantly, though, tramadol is, for all intents and purposes, as far as I've ever been able to study, is an SNRI, a serotonin norepinephrine reuptake inhibitor. And so because the central effects that it has on the noradrenergic system does help diminish some of the pain, I'm actually okay with that, and taking a look at the evidence that's a little bit scantier for Effexor. I'm even more happy, as stated, looking at tramadol as an antidepressant and pain reliever, keeping in mind that 8% of people are going to experience too much, and you do have an increased risk of serotonin sensitivity. 8% of people are going to get too little and be subtherapeutic, and the potential for pain breakthrough comes out.
Okay. The last question is a little bit of a long question, but I don't think the answer will be too involved. It is my experience that very few doctors have a good understanding of EDS, and I have not been able to find a general internist who can provide coordination of care among the specialists I see. I have been left to manage my own health care, and unfortunately this increases anxiety, depression, and in turn increases the pain in a vicious cycle. I recently went to meet a new internist, and upon reviewing my records, she commented that I've seen many different doctors for different things, and she recommended I see a psychiatrist, which I was already doing. Her interpretation of my many physical complaints was that whatever I was experiencing, it was psychosomatic and not physical. How can EDS patients respond to such a conclusion by an unaware doctor?
Oh, what a great way to end the questions. If I can be so blunt, and yes, I know this is being recorded and I really don't care, because I tend to call it the way I see it. If a patient is feeling that way, what I tend to label that is it creates a situation of lamentable ignorance. and basically the person doesn't know, and they're fixing a label, which is exactly how we started the discussion tonight. And it's too bad because it hurts people. I can guarantee you 110% it is not psychosomatic. We take a look at the literature, if we take a look at the evidence, if we take a look at simply the way EDS clinically presents, the physiological, the genetic components associated with it, it makes perfect clinical sense that an individual is more prone to have these pain and physical components associated with it, and that interplay between the pain and the mental health becomes even larger. And to call something purely psychiatric, in my mind, is a potential disservice to an individual, because we need to, if we go back to the whole basic premise, holistic health, outcome-driven objectives, personalized care, and empowerment, it's about ensuring that the person has the ability to be heard, about the ability for an individual with EDS to be respected. It's about, it's not an individual looking for sympathy, it's about an individual looking for a valid medical diagnosis, to be able to come with a clinical outcome, to be able to do what they consider to be valuable. And that's a great question, because obviously you got me going here. I think one of the things that we need to do in that particular case is use knowledge. And sometimes we have to agree to disagree, because, it's very difficult to be able to find a physician. And that's where you go back, you arm yourself with whatever papers you say. This is about empowerment, folks. You get that paper, you find the paper, because evidence talks. And, as in the expression in law goes, if you have the facts, hammer on the facts. If you have the evidence, you hammer on the evidence. If you have neither, in law, you hammer on the table. In this particular case, you get the facts, the evidence, the discussion, and with all due respect, I respectfully disagree. I've been down this road before. While there might be a psychiatric component to it, Doc, I hear you. I'm not discounting you. But my root cause is not mental health. My mental health is something that's caused because I can't do what is important to me. And if we're able to treat the two in tandem, and here's the literature that supports it, and embedded in my presentation you'll find dozens of references and citations. And just go to Google Scholar, you can get the papers, and read them. And if they apply to you, and if that gives you empowerment, then that makes me a happy person. You got me going.
Thank you so much, Doc. Thank you. We really have gotten a lot out of your talk, and we can just tell your empathy for our group and your understanding of how, we've had a lot of trouble with some doctors that have misunderstood our condition and so forth. So thank you so much. We'd love for you to come back and talk about some other aspects of psychiatry and pharmaceutical issues as well.
No, it was my pleasure. I had a lot of fun. My pleasure.
Yeah, thank you, Joel.
You guys certainly got my mind going.
Well, it's been a fabulous conversation, and we've learned a lot. And I think a lot of people got their answers to their questions as well. I just want to remind people that we will be giving our next educational webinar on July 16th, and be Dr. Rowe. So if you're interested in getting announcements about these sessions, please request the free report on our site at edsawareness.com. So appreciate everyone's attendance and your patience, and it's been a fabulous seminar. So we're going to close up for the evening, and please join us again. Thank you.
Thank you.
Thank you very much, John and Deanna.
Thank you.